the cases we did now, as you saw labeled in the syllabus, were labeled GI cases EME, meaning GI cases from the patients who would show up in the emergency room. And you know the step 3 has a sort of artificial presentation where patients present in the emergency room versus the doctor's office versus the hospital, etc. You know, that's all artificial. Just because a patient walks into the emergency room doesn't make me think, oh my God, this is something terribly emergent, and I'm going to, rush to do all kinds of aggressive stuff. It's artificial. As you know, patients walk into the emergency room because they have no doctors, they're bored, they're lonely, and they come in they have a headache. Don't automatically assume that headache is a massive subarachnoid hemorrhage just because it happens to be in an emergency room. Okay? So don't get fooled by the presentation of where the patient is showing up. Okay? Now, here the next case we see is GI, a scheduled visit. Okay? Now, patients come into my office with scheduled visits, and then they have massive aortic dissections on my exam table or in my waiting room. That's, even though they were scheduled to come in for their headache, they could have something else happen. All right? So don't be fooled by where they show up. But this guy, Westshoe, is a 52-year-old man, presents to the office with epigastric pain for 2 months, and then I'll tell you, make believe the question said, which test will confirm the diagnosis? And I'll give you choices like abdominal angiography, as if you're watching this on videotape, you can jot these down, chest x-ray, abdominal CAT scan, upper endoscopy, abdominal sonogram. All right? So right away we know, okay, guy comes with epigastric pain. This is not going to ask me about pathophysiology. It's not going to ask me about treatment. It's just how do I make a diagnosis in this guy? So to do that, obviously I have to figure out what I think the most likely diagnosis is. So let's go back to the case. Epigastric pain for 2 months. Didn't happen last night. On the other hand, it's not going on for 30 years. The pain wakes him up from his sleep. Eating, and when he takes over the counter, when he eats, and when he takes over the counter antacids, the pain gets better. He has no significant weight loss, no nausea or vomiting. He has no known history of pancreatic or ulcer disease. He doesn't drink alcohol. He occasionally smokes and takes aspirin for back pain. As I'm going through this case, is a diagnosis getting to the top of my list in my differential? This is a fairly classic presentation. Epigastric pain that is nocturnal. When we use the word nocturnal in terms of symptoms, what I mean to say is the symptom wakes him up from sleep. Okay? Epigastric pain wakes him from sleep is very suggestive of some form of acid peptic disease, whether we call it gastric ulcer or duodenal ulcer. Why is that in the middle of the night? Because we have our nocturnal acid secretion surge. At about 3 o'clock in the morning, no matter what else you're doing, your stomach is putting out a big surge of acid. Why? Because that's the way it is. Okay? And that's why we also think about when we're treating ulcer disease or gastroesophageal reflux disease, if the patient gives us a history of a lot of nocturnal symptoms, we think about giving them something right before they go to bed to suppress that acid surge in the middle of the night. But pain that wakes the patient from sleep, that's epigastric, sounds like something that is acid-related, either ulcer or GERD, gastroesophageal reflux disease. But this is epigastric pain. When he gets antacids, it gets better. It's clearly related to acid. Doesn't sound pancreatic. He doesn't have a history of ulcer disease, but this might be his first one. He doesn't drink alcohol, and he smokes. Smoking increases the risk of acid-related peptic ulcer disease and gastroesophageal reflux disease. And aspirin increases the risk of gastritis, gastric ulcer, duodenal ulcer. Physical exam, he's a healthy-appearing male in very mild distress, stable vital signs, head and neck exam, heart, lungs, all within normal limits. Abdomen is soft, really an unremarkable exam. Rectal exam, no masses, he's guaiac negative. So, you see on the syllabus there's a differential diagnosis here, but again, the question doesn't ask you what's the most likely diagnosis here. The question asks you, which test would you do to confirm the diagnosis? I mean, it's very specific, to confirm the diagnosis. Well, first of all, what's the diagnosis? If you thought the guy had a dissecting aortic aneurysm, that would have you do which test? Abdominal angiogram, or maybe a dynamic abdominal CAT scan following the contrast as it goes through the aorta. But do I think this guy has that? No. How will an aortic dissection present? Much more sudden, sometimes but not always in someone with known cardiovascular disease and hypertension, and what kind of pain? Pain more in the front or in the back with dissection? Aorta is posterior, back, and how's it described? A stabbing pain, a gnawing pain, a boring pain, a very exciting pain, a tearing pain, a gunshot wound type of pain. Tearing. As the aorta tears, the patient will often say, feels like a tearing pain. And what's tearing is the aorta. Right? That is a true emergency. Can that walk into the doctor's office? Sure, but not with several month history. Okay? So what am I thinking of is far more likely? Either gastric ulcer, duodenal ulcer. Okay? GERD, gastroesophageal reflux disease, gives more heartburn. Have I heard anything about heartburn here? No. Patient has epigastric pain. So I'm thinking gastric ulcer, duodenal ulcer. What test will confirm that diagnosis? Endoscopy. Okay? So, let's go through the other choices. Angiogram, obviously, if I'm thinking of some vascular acute problem like a dissection. Chest x-ray, of no value whatsoever. Abdominal CAT scan, well, if I thought the guy had pancreatitis, had some pancreatic lesion, it's not a bad test, but is there any reason to think pancreatic disease here? Pancreatitis, pancreatic carcinoma, no and no. Sonogram. What diseases would sonogram be the correct answer as a first diagnostic test? For gallstone disease, whether it's acute cholecystitis, it's a reasonable first test. Whether it's biliary colic, whether it's gallstones in the common bile duct leading to cholangitis, sonogram is very effective. It's not invasive. I can get the results within minutes. But does this guy have anything that sounds like biliary colic or acute cholecystitis? No. Does biliary colic typically wake you up from sleep? No. Biliary colic is related to eating, typically fatty foods, because fatty foods stimulates cholecystokinin. This is horrible nightmares from step 1 days. Cholecystokinin, which then stimulates the gallbladder to contract. So if you have a gallstone that gets stuck in the cystic duct, it will be often following a fatty meal. All right? Doesn't wake you up in the middle of the night. Is it usually epigastric? It can be, but more commonly it's right up a quadrant. Going to what area? Biliary colic, acute cholecystitis? Not the shoulder blade, the inferior tip of the scapula. All right? Pain here. Don't get these two confused. These are very specific findings. Abdominal pain, the patient says, oh man, I got pain on my shoulder. Suddenly. Something is bothering the diaphragm. So there's diaphragmatic irritation. All right? That's the phrenic nerve. Phrenic nerve does not go to the inferior scapula. Biliary colic, the gallbladder, innervated by the same nerves that will produce pain in the tip of the scapula, or interscapular pain, pain between the shoulder blades. Shoulder pain with abdominal pain is very specific. If it's happened suddenly, it means the patient's had a perforation. And either there's intestinal contents or gastric contents or just air irritating the diaphragm. Okay? The worst thing we hear when a gastroenterologist hears during a colonoscopy, oh, doc, I got a little pain here, but oh my God, I got terrible shoulder pain. That's not because they're laying on the side. It's probably because they just had a perforation during the colonoscopy. All right? So again, diaphragmatic irritation, shoulder pain. Biliary colic, cholecystitis, think about infrascapular or between the shoulder blades. This guy doesn't have this. Okay? Does this guy have any risk factors for gallstone disease while we're on the topic? No. What are the risk factors? Can he have gallstone disease? Do you need risk factors for gallstone disease? No, but it's nice if you're a woman. It's always nice if you're a woman. It's nice if you're an obese woman who's pregnant or had a lot of pregnancies, high circulating estrogens. The old fat, obesity predisposes female because, again, more circulating estrogens, which affects biliary stasis. 40 means you've just had enough years in your life to develop gallstones. All right? Flatulent, if you're flatulent, doesn't mean you have gallstones. Don't go running for a sonogram. All right? But again, can you have gallstones if you're a 50-year-old man? Sure. Does this guy have any signs or symptoms to suggest it? None at all. Okay? So I'm not thinking about gallstones. Again, peptic ulcer disease. You got a diagnosis in your head that fits perfectly. Don't think about all the possibilities. Choose the right answer and move on. And the differential diagnosis here, we talk about duodenal ulcer, gastritis, esophagitis, gastric cancer, and cholelithiasis. Duodenal and gastric ulcer, very hard to distinguish between based upon the history alone. In the syllabus, we talk about duodenal ulcer getting better with food and gastric ulcer getting worse. That's a very, very rough way to distinguish between the two of them. All right? I wouldn't say, oh, this patient definitely has a DU versus a GU, duodenal versus gastric ulcer, based upon the relationship to their meals. Okay? It could be really either one. Gastritis, again, can present with symptoms identical to ulcer disease. And again, short of doing an endoscopy, you can't tell from the history and the physical and the risk factors whether it's gastritis or ulcer disease. Gastric cancer. How does gastric cancer present? Can this guy have gastric cancer? He might. He has pain for the right amount of time. Gastric cancer doesn't present with a day's worth of pain. It's subacute or chronic. But by the time a patient presents with pain from gastric cancer, it's usually a pretty advanced cancer. All right? So they'll usually have some weight loss. They might have some gastric outlet obstruction. All right? This guy has none of that. The time frame is okay. The age is okay for gastric cancer. But nothing else here sounds like the guy has a cancer brewing. What ethnic group is most likely to get gastric cancer? Asian. All right? Doesn't mean Americans don't get it. But Americans, if you're talking about what cancer in Americans between the pelvis and the diaphragm, what's the most common by far? Colon cancer. An Asian born, especially if it's an Asian born who continues to eat a typical Asian diet, gastric. All right? Gastric or esophageal. But in the abdomen, abdominal pain, liver mets, American diet, colon cancer. Asian diet, gastric cancer. Okay? All right, what test do we do in this fellow? CBC, well, we want to know if the guy's losing blood chronically, but it's not, it's normal. Liver function tests are normal, ultrasound of the gallbladder is normal. Again, those will low down in my list. All right? If on this patient, if this was a CCS question, and the first thing you ordered was an abdominal sonogram, you'd lose points. All right? If you ordered an endoscopy, you'd get points. All right? It doesn't have to be emergent. If you did an upper GI series, which I deliberately didn't put in the choices because it's a reasonable test to do, but endoscopy is a more definitive test, where the patient drinks barium, and that will tell us whether the patient has a gastric or duodenal ulcer, that's a reasonable test. It will miss gastritis most of the time, and it also does not allow us to do any biopsies if we find a gastric ulcer. All right? So between the two, I would probably pick an endoscopy, but as a reasonable test, because it's non-invasive, because it costs less money, it's less risk than an endoscopy, that's a reasonable first test on the CCS. Okay? Normal liver function test, if I did that as my first step, I'd probably lose some points. Any liver disease cause this? Does cholecystitis cause a mild liver function test to look like this? No. All right? Amylase and lipase, can this be chronic pancreatitis? It could be. Chronic pancreatitis is usually a constant pain. Felt more in the back. Usually in someone with a history of alcohol disease. Usually not made better with meals. Almost always made worse with meals. All right? So amylase and lipase, again, it's on the list here, but if it was CCS and that was the first thing you got, I'd take away a few points. Okay? Because there's really nothing here that makes me think chronic pancreatitis. No alcohol, no pain radiating to the back, no constant pain, and no pain being exacerbated by food for chronic pancreatitis. Okay? Now, we do the endoscopy, let's say, and on the endoscopy, we find Campylobacter-like organisms. And the real name for this bug now is Helicobacter pylori. Years ago, it was called Campylobacter-like, before we actually identified it, because it looked like, in its spiral sort of way, looked like Campylobacter. All right? Turns out the species is now called Helicobacter because it's helical. All right? Helicobacter pylori. There's still a test called the CLO test, which is a test that is done on a piece of gastric tissue. Okay? Don't order a CLO test without ordering an endoscopy, because it shows the boards that you don't know how you're doing a CLO test. A CLO test, the gastroenterologist does a biopsy of the stomach, because that's where Helicobacter lives, in the stomach, typically in the antrum, takes out that biopsy from the scalp, puts it into this little CLO test, which is comes in a little cardboard packet about this big, has a little gel in it, and you put the biopsy in the gel. Helicobacter produces urease. Okay? So if it's a urease-producing organism, that yellow gel turns pink. And you look at it 5 minutes later, if it's yellow, Helicobacter negative. If If the yellow turns to pink, you've just made a diagnosis of Helicobacter infection in the stomach. You do that for 5 minutes, only costs a few dollars. Okay? It's not as sensitive. The question is it sensitive? It's not as sensitive as a biopsy and having the pathologist tell you. But then again, if it is positive, you don't get false positives. So it's very specific. All right? It's not as sensitive as a biopsy. So if it's positive, I don't really need to even send the biopsy for another $200 to have the pathologist tell me that there is Helicobacter there. Obviously, I will send the biopsy if it's a gastric ulcer and I'm worried about gastric malignancy. But if you're asked what test is specific after an endoscopy for Helicobacter, the CLO test is still a very useful test. Okay? Not as sensitive as sending it for pathology examination, but far less expensive and very specific. So we did the upper endoscopy. There's a 1 centimeter ulcer in the first portion of the duodenum with no bleeding and no evidence of gastric outlet obstruction. Our CLO test is positive, and in fact, because for no good reason, we sent it for pathology, even though duodenal ulcers, are they ever malignant? No. For all intents and purposes, every time you see a duodenal ulcer, you can assume it's benign. How about gastric ulcers? Can they be malignant? Yes. So every gastric ulcer we see, we biopsy and send it to make sure there's no malignant cells in that ulcer. Because think about it. The gastric cancer that is in fact curable is a gastric cancer that presents as just a small ulcer. By the time the patient presents with weight loss and anorexia and gastric outlet obstruction, you're talking about an incurable cancer. So we're hoping to find gastric cancers that are just superficial ulcers. And that's why in Japan and in Asia, the cure rate for gastric cancer is much higher. Because there, in Asia, because of the prevalence rate of gastric cancer so much higher, they'll do screening endoscopy looking for gastric ulcers that are malignant. Americans who have found to have gastric cancer, it's usually a far more advanced cancer. But we will biopsy every gastric ulcer to make sure that it is in fact benign. So let's talk for a few minutes about Helicobacter. Helicobacter in a patient who is not taking NSAIDs, Helicobacter is probably present in 95% of patients with ulcers. Okay? It's either going to be a drug the patient is on, like the NSAIDs, or it's going to be Helicobacter. How do you get Helicobacter? We don't know. It's transmitted obviously orally. Most people are probably infected early in life, and it's an infection that could stay there for decades. Countries that have more developed water sanitation systems have lower incidence in their population of Helicobacter. Countries where there's lesser water sanitation systems have more Helicobacter pylori. Again, it can last for many, many years and decades, and you might not even ever develop symptoms from it. It is associated with gastritis, duodenitis, gastric ulcer, duodenal ulcer, gastric adenocarcinoma, and gastric lymphoma. All right? Increases the risk for all of these. Does not mean that we're doing mass screenings for Helicobacter and treating everybody for Helicobacter because of the concern of adenocarcinoma or lymphoma. Those risks are still very, very low. Okay, but if you're asked a straightforward question, which of the following are associated or whose risk is increased by Helicobacter, all of those. Okay, Helicobacter lives in the antrum of the stomach typically, and that's where we'll typically do our biopsies if we're looking for it, and we will treat if it is an association with acid peptic disease or some pathology. If it's just there, and we happen to do an endoscopy, we biopsy, and we find it's there, there's a lot of controversy about whether we should treat it or not, and that won't be a step 3 question. But if you have an ulcer or gastritis or duodenitis, you will biopsy for Helicobacter. You'll do the CLO test. Okay? If it's positive, you have now enough evidence to treat the patient. Okay? If the CLO test is negative, then you do have to check the pathology, the biopsy results, because again, it's not as sensitive, the CLO test, as the biopsy. All right? If it's a gastric ulcer, you definitely have to send for a biopsy, again, because you want to rule out the possibility that it's a malignant gastric ulcer. We'll treat. How do you treat Helicobacter? Well, typically, there are a number of different antibiotics we use, typically in combination with a proton pump inhibitor, like omeprazole or lansoprazole or rabeprazole or any of the azole drugs. And by the time you see this video, there might be 5 or 6. All right, but the most common ones, the earliest ones, were omeprazole and lansoprazole. You use one of those and 2 antibiotics. You're not going to be asked to pick between the various antibiotics, as long as they're reasonable choices. And in the syllabus, we talk about the 4 antibiotics that are reasonable. Any of those combinations will work. So you might use omeprazole and metronidazole and clarithromycin or tetracycline or amoxicillin. All right? Any 2 of those and a proton pump inhibitor is a very effective regimen. Patients will have clearance of their HP within a week, over 90% of the time, with just about any of those regimens. What you should know about the regimens is generally we're never using just one antibiotic. We're always using multiple antibiotics to avoid the problem of drug resistance, and we're doing it in combination with either a proton pump inhibitor or with bismuth. In this country, bismuth is available as Pepto-Bismol. Okay? Again, proton pump inhibitor or Pepto-Bismol with 2 antibiotics. It's a regimen that'll go on for a week to 2 weeks tops. If you see a regimen where they're giving it for 1 to 3 days, that's going to be the wrong answer. If you see a regimen where they're treating for a month, that's the wrong answer. 5 antibiotics, the wrong answer. 1 antibiotic, the wrong answer. Okay? So you get the picture. That's the treatment. If the patient gets better after treatment from the symptoms, our patient loses his epigastric pain, he loses his nocturnal symptoms, then we don't need to do any follow-up. We don't need to do any tests to confirm the Helicobacter is gone. If it's a duodenal ulcer, we know those are never malignant, so we don't need to do anything. This patient in who a duodenal ulcer was diagnosed, we just follow the patient's symptoms. Are there tests we can do to see whether Helicobacter has been cleared if the patient has persistent pain? And the answer is yes. There are simple, non-invasive tests. One is the urea breath test. If I have a patient like this, and I put him on an appropriate regimen, omeprazole and 2 antibiotics for 2 weeks, and 2 weeks later he's still having symptoms, 4 weeks later he's still having symptoms, I don't need to repeat the endoscopy because I know the duodenal ulcer, even if it's still there, it's benign. What I want to know is, was my antibiotic regimen effective? Maybe he happened to have a resistant bug. So what I could do in that case is a urea breath test, because Helicobacter is a urease-producing enzyme. If you have urea in your breath, that implies that you still have Helicobacter. It's a simple, non-invasive breath test. There's also a newer stool antigen for Helicobacter, which, as you can imagine, is a little bit more unpleasant to do than just going and having a breath test. And there's varying sensitivities and specificities for each of these exams, and I don't want to bore you with the details. For step 3, you need to know that you will treat, that if the patient has persistent symptoms, at that point, only with persistent symptoms, would you do a test to see if the patient has cleared their HP, Helicobacter pylori, and in that case, a breath test is a very effective plan. Okay, let's move on to the case review. We talked about duodenal ulcer and gastric ulcer. Again, slight variability in their response to eating, but again, I wouldn't make that my only diagnostic criteria. Gastroesophageal reflux disease, typical symptom, heartburn. The most frequent GI disease in this country is gastroesophageal reflux disease, heartburn. Over $10 billion, that's $10 billion a year, are spent on this, what you would consider simple symptom. Not every patient with GERD has simple symptoms. Some, as you know, can have chronic symptoms that are severe, that can lead to peptic stricture, that can lead to Barrett's esophagus, and then adenocarcinoma of the esophagus. But the vast majority of patients with heartburn have just that, heartburn from gastroesophageal reflux disease, which causes pain, burning typically. Patients have different ways to describe it. Burning is the most common. They will have it after eating, because after eating you're stimulating acid secretion. They will have relief with over-the-counter antacids, H2 receptor antagonists, and most effective are the proton pump inhibitors like omeprazole. We've talked about the complications of long-standing GERD, and you also need to know the extraesophageal symptoms of GERD, gastroesophageal reflux disease. And that is that acid can not only get up into the esophagus, but could spill over to the larynx, and the patient might present with hoarseness. And a young person who presents with hoarseness, the first thing I would think of after a simple laryngitis, a hoarseness that persists in a young, non-smoking person, is gastroesophageal reflux disease. And I'd probably just treat the patient without doing any diagnostic tests if they're young. If it's an older person, certainly I have to worry about laryngeal cancers. If it's a smoker, I have to worry about laryngeal cancers. If it's a big-time smoker with a lesion on their chest x-ray, hoarseness might be from what problem? Metastatic disease from lung cancer to the recurrent laryngeal nerve, that will give hoarseness. But again, common things happen commonly. Young person with hoarseness, that's not part of a laryngitis, think of gastroesophageal reflux. If you have a patient that sounds like an asthma question, but the question makes it clear that the only time the patient has signs and symptoms of bronchospasm, and what are those? Cough and wheezing. The only time they have them is in the middle of the night that awakens them from sleep. They want you to think that this patient doesn't have the plain old asthma, allergic type asthma, autoimmune type asthma, that the patient has nocturnal asthma that awakens them from sleep, has gastroesophageal reflux as their cause. And they might not have the typical heartburn during the day. How does this happen? At night, you lay down, especially if you just ate dinner before you lay down. You now have a stomach full of food, stimulating acid, you lay down. Acid can reflux back. You're lying horizontal, so you don't have the benefit of gravity to drain the acid back out of your esophagus. And as you're laying supine, and as you're asleep, the acid is coming back. It's refluxing into the esophagus. You're asleep. It refluxes a little bit further. Your gag is somewhat impaired, so it spills over the epiglottis into the trachea and into the bronchi. You get cough and wheezing only in the middle of the night. There, they want you to look for signs and symptoms of gastroesophageal reflux disease and treat appropriately, meaning with treatment for GERD and not putting the patient on steroids and bronchodilators for asthma. Okay? So you're familiar with the two most common causes of non-esophageal or extraesophageal gastroesophageal reflux now: nocturnal asthma and hoarseness. Okay. Gastric cancer we discussed. The pain is more continuous. In this country, we usually follow it find it after the patient has had advanced disease. Often there's vomiting. Why do these patients vomit? Because if the cancer is in the area near the antrum where the stomach is trying to empty, you'll get gastric outlet obstruction symptoms: nausea, bloating, distension, vomiting. And of course, if you see supraclavicular lymphadenopathy, what's that called? Virchow's node. Virchow's on the left or on the right? Left. All right? The thoracic duct draining your lymphatics drains on the left side, and if you find a hard supraclavicular lymph node, okay, that implies a carcinoma from the GI tract. Okay? If it's an Asian person, I'll say that's probably gastric cancer. If it is an American who has lived on a Western diet all these years, I'd worry maybe about a colon cancer is more likely. Okay? But a supraclavicular node, or pancreatic cancer. Supraclavicular node is a gastric, pancreatic, or colonic carcinoma until proven otherwise. And again, at that stage, it's obviously metastatic, so that's not a good thing. Okay. Let's go on to the next question. A 65-year-old man comes to the emergency room. Again, we're back into emergency room setting now. Comes to the emergency room complaining of upper abdominal pain and vomitus resembling coffee grounds. So obviously this is someone who's having upper GI bleeding, and we could think of the various questions that we've already discussed for upper GI bleeding. The patient was in his usual state of health until about 2 months ago when he began noticing upper abdominal pain just below the umbilicus. Well, that's not so upper abdominal, mid-abdominal, and it's worsened by food. The pain has progressed over the last few weeks to be a little bit more frequent in nature. Yesterday, the patient vomited and noticed what appeared to be coffee grounds in the vomitus. He has not had any significant weight loss. He only occasionally uses NSAIDs for back pain. He's a smoker for the past 25 years, does not drink alcohol, and there is no significant past medical history. So what do I have on this patient so far? I have signs and symptoms of upper GI bleeding. I have some kind of mid-abdominal pain, and its relationship to food is that it gets worse with food. Can this be pancreatitis? Well, the pain might be pancreatitis, but then I expect it to go to the back, and I expect him not to be having GI bleeding typically. All right. So again, I'm thinking something in the ulcer family. And what evidence do I have that he may be at risk for ulcer disease? He takes NSAIDs, all right, which, again, very common cause of ulcer disease. Physical, well-appearing man in no distress, stable vital signs, heart rate is 80, no orthostatic blood pressure. So is this a big upper GI bleed? No. Okay? Head and neck exam is unremarkable, no parotid gland enlargement. So again, it's giving me some clues that this is not someone with cirrhosis and end-stage liver disease. Cardiovascular exam is unremarkable, abdomen, very mild epigastric tenderness, normal bowel sounds, no visible veins, again, something that you would see, a caput medusae, you would see with portal hypertension. This patient does not have it. He has no ascites. Brown, guaiac, positive stool, no hemorrhoids. Again, so it sounds like the upper GI bleeding in this case is almost coincidental to this patient's presentation. This now sounds like an upper source of pain. Again, same differential we had in the prior case. Here, the only distinction is, and again, I don't want to make too much of this distinction, that the pain is worse with eating as opposed to relieved by eating. Does that mean it must be a gastric ulcer instead of a duodenal ulcer? No. But again, it gives us a chance now to talk about ulcer disease again, in particular in relation to NSAID use. Now, we've discussed the differential diagnosis in detail for the prior questions. Let's move on to the discussion of what NSAIDs do to the stomach. Now, NSAIDs are very important on many parts of the boards because NSAIDs are so common and cause disease not only in the GI tract but elsewhere. Now, where are the common toxicities of NSAIDs? Well, one is obviously GI. We talked about gastritis, duodenitis, gastric ulcer, duodenal ulcer. NSAIDs typically cause esophagitis? Not really. NSAIDs typically cause esophageal ulcers? Not usually. Does it cause GERD? No. Okay? So GI symptoms, particularly ulcer disease or gastritis, very frequently presenting with bleeding. That's why GI bleeding in the elderly has not gone down in incidence over the decades, even though we have such good medications to treat ulcer. It's because elderly people are taking lots of NSAIDs for their arthritis, for their back pain. Where else do NSAIDs cause problems in the body? The kidneys. It can cause renal insufficiency, particularly in the elderly. Elderly are more prone to all the NSAID side effects. All right? They might have some underlying renal disease. They might tend to be a little dehydrated. And with some NSAIDs, they develop chronic renal insufficiency. The treatment for that is, obviously, stop the NSAIDs. And what's the other problem? Change in mental status, again, in the elderly. If you have a patient who's had a recent change in mental status, less alert, a little more confused, again, it doesn't make the patient comatose. It doesn't make the patient delirious. But again, some subtle changes in a question on the mental status after an NSAID has been started. They don't want you to do expensive CAT scans and MRIs and spinal taps, etc. They want you to think about the NSAIDs and stop the NSAIDs. Okay? Always think about drugs causing disease in the boards. Okay? And NSAIDs is one of the most common drugs you'll find on the boards as causing a sign or symptom. Now, what is the pathology or the pathophysiology of NSAID-induced gastric or duodenal problems? Here you got to review a little bit of pharmacology. Again, step 3 has maybe 10% of the basic sciences involved, almost all of it's clinical management, but they might ask you a question that indicates whether you know the pathophysiology. And in a simplified way, arachidonic acid in the cell membranes, arachidonic acid is metabolized down one of two pathways. One pathway results in prostacyclins and prostaglandins. Which is the enzyme that mediates this? Cyclooxygenase. Okay? We'll get back to that in a minute. And the other pathway results in production of leukotrienes. If you're thinking about why leukotriene sounds familiar and you haven't studied step 1 lately, because these are drugs that inhibit leukotrienes. In what disease has this been found to be effective? Asthma. Asthma, there are specific leukotriene receptor antagonists, And this pathway is metabolized under what enzyme? Lipoxygenase. Okay? And there are also lipoxygenase inhibitors for asthma. Okay? Now, when we're giving patients NSAIDs, what are we blocking? We're blocking the cyclooxygenase pathway, and we'll come back to a more detailed definition of that in a moment, not the lipoxygenase pathway. We're blocking this with NSAIDs, so we block productions of prostaglandins, which are mediating pain and inflammation. Okay? Pain is mediated by these prostaglandins. So if I could block COX enzyme, I could block prostaglandins, I feel better, less pain, less fever. Okay? They're not great antipyretics. As you know, they're mostly used as analgesics. Now, it turns out that prostaglandins is not floating around in our body just to cause symptoms. Prostaglandins do some good things. And the good things prostaglandins do is typically in those areas that we just talked about that you can get problems. And that is the GI tract, and in the kidney. In the GI tract, specifically in the stomach, prostaglandins in the stomach are good. Okay? Prostaglandins in the stomach are good because it helps protect the gastric mucosa from acid injury. Prostaglandins are important in stimulating cytoprotection, protection of the gastric mucosa cells by stimulating bicarbonate and mucus. All right, I hate to be dragging you back to step one, but this is important to know for the reason you'll see in a minute. So I want prostaglandins in the stomach. Okay? I want prostaglandins also in the glomerulus, in the kidney, because prostaglandins here stimulates blood flow. Okay? So that's why if I block prostaglandins, I can get renal insufficiency. If I block prostaglandins, I lose my cytoprotection in the stomach, and all the acid that we normally produce can now diffuse backwards into the mucosa and cause problems. Got it? Okay. Now, the pharmaceutical houses said, you know what? We got a gazillion-dollar market here with these prostaglandins, but doctors and patients don't want to use them because of these many side effects. And they have a lot of toxicity associated with it. Renal insufficiency is not a minor problem. GI bleeding from gastric ulcers is not a minor problem. So they learned a little bit more, and that is that there's good COX and bad COX. There's a COX-1 and a COX-2. It turns out that the prostaglandins that mediate pain are mediated by COX-2. So it would be nice if I could find something that just knocks out COX-2 and does not affect COX-1, because the good prostaglandins are mediated by COX-1. So I'd like to have COX-2 selective inhibitors. All right? And these are now available for a number of years, and they're common. And you need to know that drugs like celecoxib. Okay? And there are many others in this class. They all end with coxib. All right? There's about 3 on the market now. Rolficoxib. There'll be many more by the time this videotape circulates for several years. Because these drugs are about as effective as the non-selective COX-2 inhibitors for relief of pain, but are far safer in terms of stomach and renal effects. So, how will this show up on the boards? If you have a patient who has bad osteoarthritis or rheumatoid arthritis or something that requires NSAIDs, and in the question they just happen to mention that the patient had a history of ulcer disease, or the patient 10 years ago had an admission for an upper GI bleed, or has renal insufficiency with the creatinine of 2 because they're chronically diabetic. They want you to pick for the treatment of that osteoarthritis or rheumatoid arthritis or for whatever indication, or menstrual cramps where NSAIDs are used very commonly. If you have a history of ulcer disease, or especially ulcer bleeding, or renal insufficiency, the wrong answer will be something like ibuprofen or naproxen, etc. The right answer will be one of the coxib drugs, because that's when you want to spend the extra money because these drugs cost maybe 10 times more than the ibuprofens of the world, but they're safer. Okay? And if these drugs become cheaper with time, ibuprofen will disappear. And that whole class of COX non-selective drugs will disappear. Because this drug is about as effective at relieving pain, but with far less, not zero, but far less damage on the stomach or on the kidney. Okay? So it's very important. And between the last series of videotapes, if you watch Step 3 on the prior set of videotapes, when I was in my young 20s, we didn't talk about this because these drugs weren't available. Okay? Now they are widely available and should be used in patients with ulcer disease, GI bleeding history, and or renal disease. Now, let's go on to talk about the treatment of acid peptic disease that is not due to Helicobacter. Okay? First of all, obviously if there's NSAIDs, we'll stop the NSAIDs. And then how do we treat ulcers? Well, the most common way to treat ulcers these days, frankly, is to choose a proton pump inhibitor as the first-line therapy because that has the highest cure rate for ulcers. It's not really a cure because unless you eliminate Helicobacter, you're not curing the ulcer. All right? But if there is no Helicobacter, then you will get rid of that ulcer quickest with a proton pump inhibitor, faster than with an H2 receptor antagonist, and faster than with antacids. We have antacids, the least effective, the most annoying to take. It's many times a day, can cause diarrhea. H2 receptor antagonists are effective. They're very safe. These are drugs like cimetidine, ranitidine, famotidine, the adine drugs, okay, nizatidine. Those drugs are effective, but not as and very safe, but not as effective as the proton pump inhibitors like omeprazole and lansoprazole. All right. So in terms of efficacy, we're talking about proton pump inhibitors more effective than H2 receptor antagonists, more effective than antacids. In here, we could also put sucralfate, which is a drug that binds to the base of ulcers, which is not found an important niche in the treatment of ulcers. Typically, if you ask what's the most effective way to treat ulcers in terms of healing the ulcer, proton pump inhibitors. Are proton pump inhibitors safe? Yes, they're very safe. They've been around for about 15 years, and there's no long-term consequences that we're finding, even in patients who have used this drug for many years. Okay? Okay, let's move on to the next case, GI emergency case number 5. A 45-year-old man was admitted 2 days ago for an acute upper GI bleed. All right, so we're back in the hospital. Guy's already been here 2 days. Let's skip down to what the question would be. Again, this is not in the syllabus. I'm making this up for you. What is the most likely cause for this patient's condition? 1, or A, Wernicke's encephalopathy. 2, hepatic encephalopathy. 3, subdural hematoma. 4, delirium tremens. 5, acute bacterial meningitis. Okay, so it sounds like this guy's probably going to be an alcoholic and going to have some change in mental status pretty soon in this question. It's going to be my job to figure out which one of these scenarios fits best. The patient is an alcoholic with a long history of alcoholic liver disease. He underwent endoscopy on admission and was found to have a bleeding duodenal ulcer that responded to treatment with ranitidine. The patient appeared to be stabilizing, but his nurse noted that he was becoming increasingly confused this morning. Again, we're 2 days into the admission. He appeared agitated and was oriented to his name, but thought it was 1972 and that Nixon was president. And even though these tapes are not dated, it is not 1972 today when I'm taping this. The patient has become increasingly lethargic over the last few hours, and he has been on thiamine since admission. Okay? So you got an alcoholic with an upper GI bleed 2 days after coming in, he's getting confused. Now let's go through let's go through the physical and then the individual choices. But I probably have enough to already make a diagnosis. But let's go a little further. He's afebrile, BP 130/80, regular pulse, regular respiratory rate, neck is supple, lungs are clear, regular cardiac exam. He has an exam on the abdomen, soft, non-tender. His liver edge is not palpated. His splenic tip is 3 centimeters below the left costal margin, so that's obviously enlarged. Neurologic, lethargic, and uncooperative. He withdraws to pain. Hyperreflexic bilaterally, and asterixis is present. Nystagmus is not present. Cranial nerve examinations reveal no overt ophthalmoplegia. Okay, so now it's made it a lot easier to answer this question. So let's go through the possibilities. Can this be Wernicke's encephalopathy? Well, it can be, but it's not likely. Why? What are some reasons it's not likely? Number one, I don't hear about any of the ophthalmologic findings I'd want to see to help me make that diagnosis. Nystagmus, ophthalmoplegia. Okay? Secondly, why is it not likely that he has Wernicke's encephalopathy? What else have we been told in this question? He's getting thiamine. Wernicke's is a thiamine deficiency. Okay, so it sounds like this guy's been covered for the possibility of the development of Wernicke's. How about hepatic encephalopathy? Does that fit? What fits? Well, he's an alcoholic. The exam tells me he has a big spleen tip. It sounds like he has cirrhosis. He has asterixis, which is the flap. All right, it looks like the patient's waving goodbye. And if he doesn't get treated, he will wave permanently goodbye. All right, and that's a sign. It's not specific. You could have uremic encephalopathy and wave goodbye. All right, but in this setting, it sounds like hepatic encephalopathy is a good bet. And again, there's nothing specific here that tells me that he has encephalopathy, but he's an alcoholic, he's a cirrhotic, and what triggering factor does he have for hepatic encephalopathy? An upper GI bleed. He absorbs some of that blood, he converts it to urea and proteins, and the proteins and their metabolites get into the brain and he becomes encephalopathic. So that's certainly, there's nothing here that doesn't fit for hepatic encephalopathy. So far it sounds perfect for hepatic encephalopathy. Let's see if there are any better choices. Subdural hematoma. Is that possible in an alcoholic cirrhotic? Sure, alcoholics drink, alcoholics get drunk, alcoholics fall down, alcoholics bleed into their head. All right, they can have a subdural hematoma. It's a couple days later, and by now I would have expected for a subdural to have some waxing and waning mental status. Okay, which I haven't heard. Furthermore, with asterixis, with subdural hematoma, you don't have asterixis, so that makes it less likely. Certainly, anybody who's an alcoholic with a change in mental status, who's been found outside, especially if they're found outside on the ground, you have to worry about it subdural, because they fall and they typically have a coagulopathy, both in terms of clotting factors and in terms of their platelets will be thrombocytopenic. Okay, and we've been told he has a big spleen tip. But again, not typical for for subdural hematoma. Delirium tremens. Does this sound like delirium tremens? What is delirium tremens? Patient becomes delirious and tremulous. Okay, it's not the asterixis, it's just shaky. And it's delirious, and they start to confabulate and see things that aren't there. And it's typically at what time after they're admitted? Well, it's not necessarily after they're admitted, but after their last drink, which is often on their way to the ER. So it's usually a couple of days. The alcohol gets metabolized. Within a day or two, you start seeing signs and symptoms of delirium tremens. What are those? Delirium? Is he delirious? We don't quite hear delirium. We hear more agitated. And we don't have that description of someone who's in DT, delirium tremens, which is it is a hypersympathetic state where there's a lot of sympathetic nervous system discharge. So the patient gets diaphoretic. So the patient gets very shaky, tremulous, not asterixis, but tremulous. They get tachycardic, hypertensive, none of which we see here. So although it's the right kind of patient for DT, although it's the right time frame for DT, it doesn't fit the clinical description of DTs. So it's good to think about, but the wrong diagnosis. Bacterial meningitis. Well, what do we have for bacterial meningitis? He's not febrile. He has a supple neck. Can he have bacterial meningitis? It's possible, but it's really low down the list with no fever, supple neck, and we have very good evidence for hepatic encephalopathy. So that by far is the best answer here. And we also have to be concerned if the patient had ascites, that maybe this change of mental status, if he had a fever, ascites, change of mental status, encephalopathy couldn't be triggered by infection. So again, we would think about SBP. But again, we don't get a description of fevers. We don't have a description of ascites. But you always have to wonder, in a patient who has hepatic encephalopathy, is what am I missing? Or what caused the hepatic encephalopathy to appear today? This guy, we have a pretty good explanation. He's had bleeding. If he didn't have bleeding, I would wonder, am I missing some potential source of infection? And again, where would I look for an infection in an alcoholic? In the ascites. And also I'd make sure I listen to his lungs very carefully to make sure he hasn't aspirated at some point before he came in. Remember, patient aspirates, they don't necessarily have a pneumonia within 2 hours or 4 hours or even 24 hours. Sometimes, depending on the load of the aspirant, it might take a day or two until they develop their pneumonia. All right? So again, this patient, we have a clear factor why he has now developed hepatic encephalopathy. It's because he's had a bleed, he's had a chance to reabsorb that blood, and whatever metabolite it is that causes CNS alterations, and there's all kinds of different presumed neurotransmitters that are responsible for encephalopathy, whether it's ammonia or more captans or aromatic amino acids. The most likely possibility is that it's probably a GABA-like substance, gamma-aminobutyric acid. And if you think about it, that is how benzodiazepines work, is through mediation of GABA. And in fact, one quick and easy diagnostic test I could do to see if someone has hepatic encephalopathy is I say, wait a second, if he has hepatic encephalopathy, I remember that there's increased GABA transmission. GABA is what benzodiazepines stimulate. Why don't I try and reverse this effect and see if the patient wakes up and gets better? Do we have a benzodiazepine antagonist? Yes, flumazenil. If I give the patient flumazenil, typically a patient who has hepatic encephalopathy, as opposed to uremic encephalopathy, as opposed to sepsis or any other cause of change in mental status, the patient with hepatic encephalopathy would typically have an improvement in his mental status with flumazenil. The problem with flumazenil is it just lasts a few minutes, and we don't put patients on flumazenil drips. It's more important to figure out what the underlying cause of the encephalopathy is and treat it. Hopefully this fellow has stopped bleeding. We will treat him for dehydration, because that will exacerbate hepatic encephalopathy, and hopefully this will clear pretty soon. Let's look at the blood tests that we were done. CBC, white blood cell count is normal. Hemoglobin is on the low side. Platelets are on the low side. MCV is just about normal. BUN creatinine, again, suggests possible borderline suggestive of upper GI bleed with dehydration. The AST and ALT are again elevated in a pattern that is typical for alcoholics. Bilirubin, a little elevated. Glucose is normal. Ammonia is high. Ammonia is not a great test for hepatic encephalopathy, but if you're given an ammonia on the boards as part of the data that is offered in the question, and it is elevated, that's because the board wants you to think about hepatic encephalopathy. It's not something that we're in the habit of following regularly for hepatic encephalopathy, because it's not a very good correlation. But certainly, if they give you a very dramatic increase in ammonia, they want you to think about hepatic encephalopathy. Okay, and LP is done for no good reason in this particular case, and does not show white blood cells, normal glucose, normal protein. What would be the findings on a CSF in a patient with bacterial meningitis? High cell count with polys. Okay, what's the glucose? Low, because the bacteria utilize the glucose. And what's the protein? Typically high because of the inflammatory process from all those cells release protein. Okay. So, in terms of the management of hepatic encephalopathy, we correct any precipitating factors. In this fellow, it's clearly GI bleeding. We want to make sure if the patient is becoming obtunded, we protect the airway so that they don't aspirate because of this change in mental status. Chronically, what we will do in a patient who has chronic low-grade encephalopathy or a patient who is prone to recurrent encephalopathy is we'll put them on lactulose. Lactulose will help clear out bacteria in the gut that produce ammonia. And this will presumably lead to a decrease in encephalopathy. The problem with lactulose, which is a carbohydrate that's non-absorbable and is an effective laxative, is that if you give too much of it, the patient becomes dehydrated. Not only are you clearing out a lot of bacteria and ammonia production, but you're also clearing out a lot of fluid. So it's not uncommon that you give a patient lactulose, patient's a little encephalopathic to start with, they're not eating, they're not drinking, they have 6 watery bowel movements, and next thing you know, they're much worse. What that patient is telling you is that you need to give that patient more fluids and cut back on the lactulose. Lactulose, in fact, turned out to be a very good, safe, effective laxative for anybody. Okay, there's very little downside if you're using it for someone who's constipated in general. But in particularly for hepatic encephalopathy. How do you use it? Well, you try and get it titrated to about 2 soft bowel movements a day. Okay? Much more than that, and you're going to get the patient dehydrated. They'll probably get worse. If it's not that much, then you're not giving enough of the laxative effect to have any benefit on the encephalopathy. Okay. We're going to limit dietary protein, especially animal-type protein. And if all of this fails, we can give a non-absorbable antibiotic like neomycin. Now, neomycin sounds like gentamicin or tobramycin, but it's not an aminoglycoside in a way that will cause nephrotoxicity. And why doesn't it? Because it's non-absorbable. So it does not get into the bloodstream. It stays exactly where we want it, in the lumen of the bowel, and it will clear out a lot of bacteria that would otherwise be sitting there producing ammonia. The other place you'll see neomycin used is in a patient who's pre-op, and we want to get a bowel prep. We'll typically give non-absorbable antibiotics, and one of them tends to be neomycin to clear out intestinal flora. Okay? Okay. We've already discussed in terms of the case review, we've discussed hepatic encephalopathy. We've talked about precipitating factors, drying the patient out. Some of these patients have ascites, so we're giving them diuretics. Just like you can make a patient dehydrated with laxative, you can make a patient dehydrated with diuretics, obviously, as well. Be very careful. If you're giving any alcoholic with liver disease, benzodiazepines. Now, when would you ever think of using benzodiazepines in an alcoholic? When is it, quote, the treatment of choice? We've already mentioned it. In delirium tremens. There, the patient is very agitated. We want to calm the patient down, so we'll give benzodiazepines. Always look to use short-acting benzodiazepines. Why is that? Because remember, you could take a patient with alcoholism and liver disease who's in DT from alcohol withdrawal and hypersympathetic, calm them down with some benzodiazepines, but then the benzodiazepines, which are supposed to be metabolized in this liver, and now we got a sick liver, the benzodiazepines hang around for a long time, they potentiate GABA transmission, and now you've taken a shaky, delirious patient with DT and converted them into a patient with hepatic encephalopathy. So be very careful when you're treating DTs. By definition, you got an alcoholic. Many of those alcoholics already have chronic liver disease and portal hypertension. If you give them benzos, you have to watch very carefully. Small doses and short-acting benzodiazepines. Okay, we talked about treating them with lactuals and non-absorbable antibiotics. We talked about DTs, usually within 1 to 2 days of stopping the alcohol, and the boards might give you a scenario where they don't say this is some homeless alcoholic who has cirrhosis and an SGOT of 200 and an SGPT of 100 and who's had multiple admissions for alcoholic hepatitis and 5 variceal bleeds. A question that they keep putting on the boards is a patient with DT who just happens to be a physician, who just happens to be admitted to the coronary care unit. And they want you to figure out, by the fact that he's starting to get confused, this particular description has appeared many times. Somebody who you deliberately, the board makes you think, you wouldn't automatically think of a chronic alcoholic. But they tell you they're in the hospital for some other reason, and about 2 days in they start getting very shaky, delirious, and look just like your DT patient. They want you to think about a history of alcoholism that you didn't know about. Okay? So if it smells like, it looks like DTs, think about whether it's DTs, even if you don't get the information that the patient's a chronic alcoholic. Okay. Wernicke's encephalopathy, typically it's not your well-nourished, overweight physician who's in the CCU, who's well-nourished and just happens to drink too much. That patient ain't going to get Wernicke's encephalopathy. Who will get Wernicke's encephalopathy? Someone who's not eating, an alcoholic who is perhaps homeless, not have enough money to buy meals, living off his calories that he gets from alcohol, not eating much thiamine, so they have deficient thiamine stores. Why this alcoholic who's gone through his last 30 years of drinking happily, living on the streets, has never had Wernicke's encephalopathy, we put him into our wonderful health system, and within 48 hours he gets encephalopathy. What's happened? What's happened is this guy had a little bit of thiamine left, just a little, just enough to get by from day to day. Now what we did is he comes into the hospital, he gets intravenous infusion with glucose, okay? Maybe saline with glucose, but glucose. Once you get that glucose in, he now has glucose to start up a lot of metabolic pathways that utilize that little bit of thiamine that's left. All right, so it's not the admission to the hospital. It's not an antibiotic. It's not the scenery in the ER that makes him Wernicke's encephalopathic. What it is you've given the patient glucose. And the question will tell you they got intravenous fluids. They usually will tell you it's glucose. And from there you have to infer that the patient is now become, iatrogenically, thanks to the glucose you've given, has become thiamine deficient. And will get delirious, that looks like DTs, but will also have ophthalmoplegia, nystagmus, double vision. That is not DTs. That is something there very specific to make you think of Wernicke's encephalopathy. The treatment for that is thiamine. Okay? In fact, is there any danger in giving someone thiamine? Can you make someone thiamine toxic by giving them a shot of thiamine? No. And in fact, the paramedics around the country, if they find the patient unconscious, they give the patient a so-called cocktail. Now, they don't give the patient, a martini. They give the patient a cocktail of 3 drugs that are essentially safe if the patient is diminished mental status, and is likely to reverse several common causes of decreased mentation. And what is in that cocktail? Well, one is thiamine to treat this, frankly, uncommon problem, but so easy to treat thiamine, and you're not going to make anyone sick with a dose of thiamine. The second thing you would do is if you have an unconscious patient or barely alert patient, and you don't know the history, what are you going to do? Give glucose. How do you know this isn't an insulin-dependent diabetic who took some insulin and now is very hypoglycemic? Okay? Well, you say, wait a second. How do you know he's hypoglycemic? How do you know this isn't a DKA patient or a non-ketotic hyperosmolar coma patient and his sugar's already 700? The answer is you don't, but you don't have so much time to figure it out and be real smart about it. You give the glucose. If the sugar's already 700, it'll go from 700 to 800. You haven't killed him. All right? You'll have to treat for an extra hour later. If, on the other hand, it's hypoglycemia, you can't afford to be hypoglycemic even for a few more minutes, and you take the chance and you give them the glucose. So it's thiamine, glucose. What's the third thing we'll give that unknown stranger who's naloxone or Narcan? Because you don't know that person hasn't had a narcotic overdose. Okay? Particularly some person laying in the street, some homeless, somebody who looks like they're disheveled, etc. They give you other clues might be prone to the risk of IV drug use. You'll give the Narcan, naloxone. So thiamine, glucose, and Narcan. And the EMS, the paramedics, will come into the ER and say, he's already gotten the cocktail. That means they've already addressed the problems of hypoglycemia, Wernicke's encephalopathy, and narcotic overdose. The next case is GI scheduled visit number 3. A 27-year-old woman comes to the office with 8 months of diarrhea, weight loss, and a pruritic skin rash. All right, so my mind is thinking back, all those diseases that have diarrhea, with weight loss, with skin, your head's spinning. All right. The question is going to say, for instance, which of the following would be useful in making the diagnosis in this patient? Rectal biopsy, jejunal biopsy, gastric biopsy, ileal biopsy, cecal biopsy. Okay? So there's going to be some disease that has a diagnostic test somewhere in the GI tract. Okay? Now, obviously, I'm going to figure out what disease it is, and hopefully I'm going to get more clues than that first sentence. There's no blood or mucus in the diarrhea. Okay? So that doesn't sound like what? Bloody mucus. Doesn't sound like a colytic process. All right? So right away, rectal biopsy, I don't know. She is a very anxious person, has recently been more depressed. I don't know what that means. She is very frustrated because she cannot identify a cause of the diarrhea and has become obsessive about eating only food that she is sure cannot be contaminated with any possible form of food poisoning. Typically, what are we worried about in food poisoning? What kinds of foods? Fruits, vegetables, meats, eggs, fish. Do you think of anything else? That basically covers it, right? If I told you I ate a pretzel, are you worried about food poisoning? No. If I ate sucking candy? No. If I ate a a greasy burger that was sitting in my car in the hot sun on 56th Street for the last 4 hours while I was lecturing, and had ketchup and onions and pickles and stuff melting in there, would that be more likely? Yes. Okay? So we're getting some clue about what forms of food she's avoiding. She denies fevers, abdominal pain, or bleeding, and her appetite is excellent. Her temperature is 37 degrees, blood pressure okay, pulse okay, respiration's okay, eyes, ears, nose, throat, neck normal, chest is clear, heart normal, abdomen soft, non-tender, somewhat distended with hyperactive bowel sounds. Rectal exam shows guaiac negative brown stool. Again, that's going against a rectal proctitis type of process. She has a diffuse papulovesicular rash over her elbows, knees, buttocks, and back. Okay? Now, here it would be helpful just to review, because we can't make a diagnosis yet. I mean, I can make some good educated guesses, but I deliberately give you a case like this because there's limited information to make you really think. And here it would be helpful to remember what diarrheal illnesses have what GI diarrheal illnesses have skin manifestations. And there's a couple. One is inflammatory bowel disease, ulcerative colitis, and Crohn's disease. And what skin manifestations with that? Erythema nodosum and pyoderma gangrenosum. What do they look like? They might show you a picture. Erythema nodosum, red, raised nodules, typically on the shins, the lower extremities. And they're tender, they hurt, they're inflammatory. All right? And patient might initially think it's a bug bite, but it's very tender, red, and they can have multiple lesions. Pyoderma gangrenosum, it's pyo, it's pustular, it looks infected, and it can be gangrenous. Pyoderma, pus of the skin, gangrenosum, it can ulcerate deeply. Irregular borders, weeping, mucoid discharge from the skin, pustular discharge. Those two are seen with inflammatory bowel disease, whether it's ulcerative colitis or Crohn's disease. Another diarrheal illness that has a particular skin, and there's a description of a diffuse papulovesicular rash, sound like either one of these? No. How about glucagonoma, which you might work for the next 60 years of your life and never see it, but it ends up every year or two on the boards. Glucagonoma, an extremely rare neuroendocrine tumor that produces glucagon. No mystery. What does glucagon do? Gives you, what does insulin do? Lowers your sugar. Glucagon is the counter-regulatory hormone, raises your sugar. And it also produces diabetes. Typically, it's an OMA, again, a tumor located in the pancreas. And it's a rare disease associated with a rare skin finding. And what is that? NEM, necrotizing erythema migrans. Necrotizing, it's a destructive necrotizing skin lesion. It's red and it migrates. Okay, so one day it'll be on the leg, the next day it'll pop the arm, the next day it'll pop up on the leg. All right, very red, can be painful, often described as serpiginous, well demarcated. NEM, necrotizing erythema migrans, very rare. Is that what this patient has? No. Lastly, and maybe you could think of some more that are even lengthen this list, but the far most common ones of diarrhea and skin is celiac disease. Celiac disease. And what's the skin lesion there? Very good. Dermatitis, inflammation in the derma, in the skin. Herpetiformis. Is this a herpetic infection? No. So why is it called herpetiformis? Because, like herpes, it causes vesicles. Okay? Vesicular. Does this patient have a vesicular type rash? Yes. So right away, since I've thought very carefully about the information I've gotten, I already think that celiac is a very likely diagnosis. Is there anything in this case that doesn't fit for celiac disease? What's all this babbling about her diet in the question? Does that help me? Well, she's avoided meats and fish, fresh fruits, vegetables. Should that make her diarrhea better? No. Okay? Because she's still eating bread, and pretzels and cake, and those things are usually not infected, so she thinks she's ahead of the game, but she's poisoning herself, okay? So celiac disease is my most likely diagnosis already, okay? Now, let's look at some blood tests and some other tests. Let's go back to the question I asked you first. What biopsy will be helpful here? Rectal biopsy? No, rectal biopsy might be useful for ulcerative colitis. How about a jejunal biopsy? Yes, that will be diagnostic. All right? It's a very sensitive way to pick up celiac disease. The villi, those little finger-like projections in the jejunum, which can be reached with a gastroscope, a long scope from above, with celiac disease, by definition, will be lost. You'll have villus atrophy. Okay? Now, is celiac sprue the only thing that causes villus atrophy? No. If I get viral gastroenteritis at lunchtime, tomorrow I might have diarrhea, and if I did a small bowel biopsy, which there would be no indication to do, I will have found that my villus have atrophied. But in a week or two, eating all my pizza and bread and cake, my villi will grow back as I clear the viral gastroenteritis. In celiac disease, you have villus atrophy that don't grow back unless you're on a celiac diet, meaning gluten-free diet. So although the finding of villus atrophy is necessary for the diagnosis of sprue, it's not specific. It's not pathognomonic. What is pathognomonic is if the patient who has villus atrophy is put on a celiac diet and the villi grow back, and then I give the patient some gluten again, and then they disappear, the re-challenge, that's pathognomonic for celiac disease. We rarely have to go that far and make the patient sick on the re-challenge to make the diagnosis. Okay? So, where would I want a biopsy for celiac disease? Jejunum. And so far, that's the most likely diagnosis. Gastric biopsy help with diarrhea? I can only think of one cause of diarrhea, that a gastric biopsy. This is rare, and that's Menetrier's disease. Not Meniere's disease where you're dizzy. Menetrier's disease where you get thick gastric rugal folds, and they weep and weep and weep and leak and leak and leak protein. All right, and they end up with a diarrhea and very hypoalbuminemic. That's not the picture I'm getting here. Okay? So gastric biopsy is a very long shot. Nothing here to suspect anything wrong in the stomach. Ileal biopsy. Ileal biopsy. I remember there's a disease that has a skin lesion that causes diarrhea, and it's in the ileum most commonly. That's Crohn's disease. Anything here for Crohn's disease? What's for Crohn's disease? 8 months of diarrhea. Is that the right time frame for Crohn's? Yes. Crohn's and ulcerative colitis are chronic diseases. Never make the diagnosis of ulcerative colitis or Crohn's if the question tells you the patient's had symptoms of diarrhea or bleeding or pain for a day or two. It's going to be at least weeks or months. So that doesn't fit. That does fit. 8 months fits. Weight loss, does that fit? Yes. Skin findings, yes, but these are not typically pruritic. Okay? All this changing in food doesn't really help me much, and there's nothing on exam to suggest any right lower quadrant findings. And lastly, the skin lesion is not typical for Crohn's. So although the chronicity of it fits, the weight loss fits, the skin rash, the absence of any right lower quadrant findings on exam makes me less likely to suspect Crohn's disease. Is this the right age for Crohn's disease to develop? 27? Absolutely. It's a disease that strikes typically teenagers, people in their teens, 20s, 30s. I'd be reluctant to make the diagnosis of Crohn's disease in a 70-year-old. Can it happen? Yes, but it's far less likely. Most patients with Crohn's or ulcerative colitis will have their onset in their teens, 20s, and 30s. And cecal biopsy, is there any specific disease that I would biopsy in the cecum? I can't think of one. Okay? So right now, since I'm thinking the most likely cause based upon the information I have is celiac sprue, if I'm asked which biopsy would be helpful, a jejunal biopsy is by far the best choice. Let's look at some of the blood tests that might be helpful in celiac sprue. CBC. How would a CBC be abnormal in celiac sprue? And here I have to go back to step 2 material. Not quite as bad as step 1. And in general, if you're studying for step 3 and you have your notes from step 2, you found your notes very helpful. Step 2 is very helpful for step 3. It ain't enough, but you can't pass step 3 if you don't know all the basic clinical information and pathophysiology from step 2. So at least this is step 2 material, and not step 1. And so you need to remember where celiac sprue involves the gut, and what doesn't function right when that part of the gut doesn't work right. And celiac sprue here's your colon. There you go. There's 25 feet of your intestinal tract, right there. Where does celiac sprue attack? Well, first of all, you know it's small bowel, not large bowel. And it's important to remember celiac sprue preferentially involves the proximal small bowel. Okay? It might involve the entire small bowel, but when it does, it's still going to be most severe in the proximal small bowel. And if you remember from step 2, there are 3 things that are absorbed in the proximal small bowel and not well compensated for distally in the small bowel. And the mnemonic I use is FIC. Has nothing to do with the FIC equation. Don't get nervous. I'm not going to ask you to do any calculations of cardiac output. FIC is just my goofy mnemonic to remember folate, iron, and calcium. So if I have sprue and the proximal small bowel is not absorbing, the distal small bowel can't help me out very well because this stuff is not absorbed in the distal bowel. So a patient might present with folate deficiency, even if they're eating no amount of folate. They might present with iron deficiency, even if they're eating a diet full of red meat. And even if they're eating a diet full of red meat and have no bleeding, and they have iron deficiency, right away I'm going to think of malabsorption. If you're eating enough of it and you're not losing it, then you're not absorbing it. Okay? And that might be a presentation of a patient with sprue on the board. Patient who seems like all the world they have iron deficiency. They tell you the MCV is low. They tell you the iron binding ratio is low. They tell you the ferritin is low. They tell you the smear is hypochromic microcytic. They tell you the MCV is 65. They tell you that you've guaiaced the patient 400 times in the last 6 months. The patient's not menstruating. The patient has no hematuria. How many more ways can they tell you? And the patient eats red meat 3 times a day. They're eating it, they're not losing it, and you know the patient has an iron deficiency, they're not absorbing it. Okay, so sprue can present as an iron deficiency anemia. And lastly, it can present with osteopenia or osteoporosis or other signs of chronic hypocalcemia because they're not absorbing calcium well. Okay, folate, iron, and calcium. And those are 3 tip-offs in terms of selective deficiencies that too should make you think of celiac disease. So in terms of our CBC, what I would look for is perhaps signs of an anemia. The H&H might be low, and the MCV might be high if it's folate deficient. MCV might be low if the patient is iron deficient. Sprue in and of itself does not cause GI bleeding. All right, so an anemic patient with sprue, look at the MCV. If it's very high, the patient probably needs folate. If it's very low, the patient just needs supraphysiologic doses of iron. So we talked about the differential diagnosis for this patient. We talked about inflammatory bowel disease with skin changes. We talked about the extremely rare glucagonoma. And we talked about celiac sprue and why this diagnosis is celiac sprue. Let's talk about the different diagnostic tests for small bowel malabsorptive disorders. How do we define a patient with malabsorption? Patient's eating the usual amount and is either not gaining weight or more typically losing weight. They're having diarrhea, often large, foul-smelling, bulky stools, and there will be signs of various vitamin and mineral deficiencies, as we already discussed, in terms of celiac sprue, for instance. Now, what are some of our diagnostic tests, and when will you pick them as the right answer? Well, it depends on what diagnosis you're thinking of. There's no sort of automatic sequence of tests to order. Rather, you think about what kind of diagnosis you have in mind, and then you pick the most appropriate test. So, if I think the patient has a small bowel malabsorption process, the best single test to do is a D-xylose test, because D-xylose is a simple sugar, requires no metabolism, requires no digestion in the small bowel. All it requires is an intact small bowel villus surface. Okay? So if I give you a cup with 50 grams of D-xylose, ask you to drink it, and if 2 hours later D-xylose shows up in your bloodstream, then I know you're absorbing well. So you've ruled out a malabsorptive disorder with a single D-xylose test. D-xylose test tells you that the small bowel mucosa works well to absorb. Very simple, straightforward, inexpensive, non-toxic test. If the D-xylose test is normal, then we know we're not dealing with a small bowel malabsorption, and then I would think about pancreatic causes of malabsorption. We'll get that in a few minutes. If it's abnormal, then I know that there is something wrong with my small bowel mucosa, its ability to absorb. And then I will do a small bowel biopsy. Now, there's a whole very long list of small bowel malabsorptive diseases. I would basically want you to know two. One is celiac sprue, and the other one is tropical sprue. And the clinical presentations are different, the kind of patient is different, and the deficiencies are different. Tropical sprue, you must get in the history that the patient has been in a tropical region. Okay? This part of the world, people travel most commonly to the Caribbean. But India, Southeast Asia, etc., they come back from one of those areas and they develop a malabsorptive disorder. They're eating, but they're losing weight. And they have a specific nutritional deficiency with tropical sprue. And here it's important to know that celiac sprue affects the proximal small bowel. Here's the ileum. Celiac sprue is up here. Tropical sprue is down in the ileum. And as you might remember for steps 1 and 2, what's absorbed in the ileum? B12 and bile salts. So if you become B12 deficient from tropical sprue, you will have what kind of anemia? Megaloblastic with a high MCV. Okay? Those patients, the high MCV, anemia, megaloblastic patient can happen with folate deficiency in celiac disease or B12 deficiency in tropical sprue disease. You need to base your diagnosis there on the clinical history. Patient came back from the tropics, think this. Patient has a chronic disease with malabsorption, folate, iron, calcium malabsorption, think celiac sprue. As an aside, if I'm suspecting celiac sprue, there's a very good antibody test, several antibody tests that will suggest the diagnosis of sprue. It's not the gold standard. Gold standard, I want a small bowel biopsy for either of these diseases. But if you're given a patient and they describe, like in our patient, a patient who you think has celiac sprue, and they say, which of the following antibodies is consistent with the most likely diagnosis, then they'll give you a list of antibodies. And for celiac sprue, the antibodies are, the most specific is anti-endomysial antibody. And another one you might see is anti-gliadin. These are very specific, not 100% sensitive, but very specific for celiac sprue. And they're also useful because if your patient with celiac sprue starts getting diarrhea again after they tell you they're on a gluten-free diet, if these blood tests become abnormal, then that suggests that they're probably cheating on their diet. Because as the patient adheres to a sprue diet, a gluten-free diet, no wheat, barley, or rye, and some patients can't eat oats either, then these antibodies disappear. As the sprue gets worse, these antibodies reappear. So it's a nice way to follow the disease if the patient's having some level of symptoms. Okay, so that's the approach to a small bowel malabsorptive. D-xylose small bowel biopsy. And we talked about the clinical presentations of celiac sprue and tropical sprue. If D-xylose is normal, then I want to think about what are the other possibilities. And the most typical one that you'll need to know for step 3 is the patient have a history of chronic pancreatitis? Who will have chronic pancreatitis? In this country, 99.9% of the time, alcoholism. Okay? Gallstones don't cause chronic pancreatitis because if a gallstone gets stuck in the papilla vata, you can have very fulminant acute pancreatitis, but that doesn't stay around long enough for the patient to develop chronic pancreatitis. Either the gastroenterologist or the surgeon goes in to remove the stone, or the stone passes on its own, or the patient dies from fulminant pancreatitis. You can't have gallstone pancreatitis causing chronic pancreatitis. So this will always be a patient with a history of ETOH abuse. And these patients don't always give you a history of recurrent episodes of acute pancreatitis. They may just present with chronic pancreatitis, and somewhere in the history they'll tell you that they have alcohol abuse. It causes chronic fibrosing in the pancreas. You get pancreatic endocrine insufficiency, meaning the patient becomes diabetic. And you also get exocrine insufficiency, meaning the patient develops poor digestion of all three major food groups: carbos, because you don't have amylase; proteins, because you don't have all your proteolytic enzymes, okay? Trypsin, chymotrypsin, proelastase, etc. And you also don't digest fats because you don't have lipase. All right? That's a patient with chronic pancreatitis. Look for a history of ethanol abuse. There'll be a patient with malabsorption who the D-zolus is normal. History of alcoholism, it's chronic pancreatitis. The treatment for this is, remember, it's pancreatic exocrine insufficiency, digestive enzyme insufficiency, and what we can do very simply is replace the enzymes. We give the patient pancreatic enzyme replacements. Okay? Very simple, straightforward approach to patients with malabsorption. Okay. Inflammatory bowel disease we're going to discuss in an upcoming case. Irritable bowel syndrome. We don't have a case in the syllabus for irritable bowel syndrome, but I could tell you in real life, for every patient you'll see with celiac sprue, for every patient you'll see with tropical sprue, for every patient you'll see with ulcerative colitis or Crohn's disease, you'll see 10,000 patients with irritable bowel syndrome. Irritable bowel doesn't make itself into the boards in too many questions because it's sort of a boring disease, but the boards is trying to get more and more real, everyday-like. And so you might see patients with irritable bowel. Who is the patient with irritable bowel? Just about everybody in this room probably has had irritable bowel from one time or another. Some people just have the symptoms and don't think twice about it. Some people, it's something that they think about every day. Some people even go to their doctors for it. What is it? You've all taken tests. That nervous, crampy feeling you get before a test, that crampy, spasm, irritable gut feeling, sometimes it sends you running to the bathroom with diarrhea, the so-called butterflies in your stomach, and running to the bathroom when you're nervous. That's what the irritable bowel is. It's the bowel is irritated. By what? By stress, by certain foods, and sometimes by we don't know what. But that's the feeling that these patients with irritable bowel syndrome have all the time. They'll have that crampy abdominal pain in association with either diarrhea, as I just described, or some irritable bowel patients, typically young women, typically young, healthy, thin women, will tend also to have a lot of constipation as part of their irritable bowel syndrome. And they'll tell you they go days and days and days without a bowel movement, they get distended, they feel like they're 6 months pregnant, and they don't find relief until they finally have a bowel movement. So there's the diarrhea predominant irritable bowel, there's the constipation predominant irritable bowel, and then there are those patients who say, yeah, I have diarrhea for 3 days, I can't stop going, and then I'm constipated for 6 days, I can't go, then I have 3 days of running to the bathroom. What unites all of these is that there's crampy abdominal pain somehow related to an alteration in the bowel movements in either direction. By definition, if you're calling it irritable bowel syndrome, there's no itis, there's no colitis, there's no ileitis, there's no enteritis, there's no itis, there's no inflammation. So these patients don't have weight loss from irritable bowel, they don't have fevers, they don't have anemia, they don't have high SED rates, they don't have guaiac-positive stools, okay? They can have lots of symptoms, be a lot of pain, and some people are even fairly disabled by this, but again, most people have it and are not even aware of it, okay? The treatment for irritable bowel is alterations in diet. Typically we ask them to eat more fiber because that helps make the stools more regular, and we give them antispasmodics for the intestinal tract if they're having a lot of pain. But those are only given, the medications, if by trying to change the diet we haven't improved the patient. First step is diet. Tell the patient try and relax, which works that easily. Tell the patient relax and they'll relax. It's stress reduction and dietary change. If that doesn't work, antispasmodics. Okay? That's the irritable bowel. These patients are not admitted to the hospitals, and again, they do not have any inflammatory signs or symptoms. Okay, let's move on to the next case. Schedule visit number 4. Chief complaint, the food gets stuck when I eat. A 55-year-old man comes to the office complaining of progressive difficulty swallowing food over the last 3 months. Let's skip down to where you can imagine there's a question. And the question will read, what diagnostic test will you order? Esophageal manometry, chest CAT scan, endoscopic ultrasound, upper GI endoscopy, or abdominal CAT scan. All right? So it's very straightforward. This is a guy who's going to have some kind of esophageal problem, probably, and we're going to figure out what diagnostic test based upon what our diagnostic suspicion is. The patient states that he initially noted that meat was difficult to swallow and it appears to be getting stuck in his mid-chest. He was able to avoid these symptoms by careful chewing. Over the last 2 months, he began to have difficulty with all solid food and notes that last week he began to regurgitate liquid. He notes weight loss of 25 pounds over this period. He has a history of, can't wait to find out, smoking 2 packs per day, and he drinks socially. For those of you not familiar with this expression, drinks socially, quote unquote socially. All right. First of all, the boards will not say socially, quote unquote. Whenever you see someone say quote unquote, it's like winking. It's like, yeah, he drinks socially, as to imply no, he's a down in the street gutter alcoholic. All right. When someone says, or sometimes the boards might use the expression, he's a social drink, that implies he only drinks at social occasions. Social occasions when he sees his wife in the morning, when he goes to work and sees his employees, when he gets into a cab and sees the cab driver. All these are social occasions. Social occasions means to imply that you drink occasionally, as opposed to drinking all the time in so-called addiction to alcohol. All right? This has a certain implication when you say the patient drinks socially. But again, it's in quotation marks. He states that he has had blackouts in the past associated with drinking. I've gone to a social affair from time to time. I don't have blackouts, all right? Social drinking, quote unquote, and blacking out are not entirely compatible. And the boards want you to recognize, now that you're experienced in step 3, and you're men and women of the world, you know that some people actually lie about the volume of alcohol they drink, all right? So the boards expect you to cast some suspicion on patients who say they drink only socially. He states that he's had blackouts associated with drinking. He's disheveled and cachectic appearing. Okay? He's afebrile. Blood pressure is okay. Pulse is okay. Respiration is okay. Poor dentition, but no lymphadenopathy. Poor dentition, again, just means poor dental work. Your teeth don't look so good. Your gums don't look so good. It's almost a code word for people who are down on their luck, don't eat well, don't have money for dental care, maybe they're homeless, maybe they're alcoholics, maybe they're drug abusers, etc. Okay? That doesn't mean if you have 2 cavities that you're destined to live a life of drug addiction on the streets. All right? But poor dentition often goes along with this sort of general phenotype of being an alcoholic. Okay? There are clues you're going to look for on the boards and in real life. Patients don't always volunteer that I drink 4 bottles of tequila every day by breakfast. But you'll look for these clues on the physical and on the question. His chest is clear. He has a regular rate and rhythm with a normal S1 and S2. His abdomen is soft, non-tender, no hepatosplenomegaly. Rectal exam shows guaiac, positive brown stool. His extremities are normal and have no edema. So what do we have in this guy, this social drinker? Well, what symptom does he have in a word? One word. Dysphagia. Is he describing odynophagia? No. What is odynophagia? Pain with swallowing. Dysphagia means difficulty. Okay? Dysphagia is dysphagia, trouble swallowing. Now, all dysphagia, all esophageal diseases that cause dysphagia can be divided into one of 2 simple groups. The mechanical type of dysphagia and the motility type of dysphagia. How do you know which one the patient has? Does the patient come and say, I have a mechanical dysphagia? No. But they describe symptoms of a mechanical problem, a blockage. And blockages in the esophagus don't happen like that. They take some time to develop. And it's all about the caliber, the width of your esophagus. Your esophagus is, let's say, about this big. So if you take a big piece of steak, it'll get through. If the esophagus is about this big, if you get a big piece of steak in there, it won't get through. But if you eat soft chicken, it'll get through. If you eat pasta, it'll get through. If you drink, it'll get through. A month or 2 later, whatever is causing that blockage is now this big. So now you're having trouble with soft chicken and fish and pasta and maybe all you could eat is mush, baby food, oatmeal. And then when it's this tight, as in this guy, he has trouble even with liquids. So that description of progressive narrowing, you're able to tolerate less and less, tells you there's a mechanical problem. Okay? Let's just talk now about the different types. Motility means the esophagus, again, you remember, you don't swallow, and food doesn't just sort of fall from your mouth to your rectum. There's peristalsis from the upper esophagus all the way down to your anal sphincters, right? There's an orderly peristaltic wave. This holds true for the esophagus as well, right? We don't have to stand upright every time we drink so that food falls down into our stomach. We could drink lying down, and drinking and food manages to get down because of ordered sequential peristalsis. And we depend on that not just for solids but for liquids too. So if a patient says, I can't swallow, the first question is, what can't you swallow? If the patient says from the very beginning when the symptoms started, no matter what I took, whether it was a big piece of steak or whether it was just a drink of clear water, I had trouble. It would feel like it was not getting down, it was sitting in my chest, it would get stuck, I would gurgle it up. That implies not that there's a mechanical blockage, because if there was, fluids would get through, but that there is a motility disturbance. Okay? And we'll talk now in a few minutes about the various motility disturbances. This patient is describing mechanical dysphagia. Now, what would cause this mechanical dysphagia in general, and more importantly, particularly in this patient? He's lost a lot of weight, so this is pretty profound dysphagia. He has a history of smoking, yes, right? Yes, 2 packs a day, and he drinks. Smoker, drinker, mechanical type dysphagia with weight loss has what disease until proven otherwise? Cancer. So he has esophageal cancer. I could say that with a very high probability that he has esophageal cancer. Can I tell what kind of cell type that cancer is based upon this history? Well, statistically speaking, most of the esophagus is squamous. Okay? Basically from the very top of the esophagus just to your squamo-columnar junction, which is where your stomach meets the esophagus. So you would expect most to be squamous, and most are squamous. Especially those who have their risk factors of smoking or drinking. The other kind of cancer cell type in the esophagus is adenocancer, adenoCA, and that happens, the lower esophagus, in association with what underlying process? Barrett's esophagus in someone with long-standing reflux. All right. Now, can you present with adenocarcinoma without a known history of Barrett's, without reflux? Yes. But if the question is going to great lengths to tell me this is someone who's been suffering with heartburn for 50 years and all kinds of medications, yada, 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 I'd say maybe it's an adenocarcinoma. Again, I don't know that for sure. People with reflux can also get squamous cell, but again, if they're making a strong point of reflux, think about adenocarcinoma arising in a Barrett's esophagus. What are some benign causes of a mechanical dysphagia? Peptic stricture, meaning with chronic reflux and chronic inflammation, you can get scarring, and a smooth, tapered stricture. All right, and that's also progressive, but not usually associated with so much weight loss. Okay? And this usually takes longer to develop. It's a benign process, slowly progressive. These are the major ones. If I give you one particular kind of mechanical dysphagia, where I tell you it's very episodic, has an episode, I eat a piece of steak tonight and it gets stuck here and it takes me hours till it gets down, and then I'm fine. I could eat steak every night for the next 6 months, and 6 months from now I have another episode where a piece of steak gets stuck. What should that suggest? That should suggest a Schottky ring. And what's a Schottky ring? At the very bottom of the esophagus, there's a ring where the lumen is narrowed. And why is it episodic? Because it's a soft, flexible ring. And unless I eat some piece of food that's way too big to get through, I'm okay. Most things get through because, again, it's soft. But if I eat a bigger piece of steak tonight than usual, it might get stuck. And it might take some while till it sort of dissolves itself and gets through. And I might eat steak for the next 6 months and just happen to be chewing a little more carefully until I have another steak. And typically it's when people are drinking is often part of the clinical scenario because they're not chewing as well, they're taking bigger gulps, and they end up with another obstruction. This is the diagnosis is based almost always by the history. There's no history of slow progression. There's an episode of dysphagia, and then maybe none other for many years. And the diagnosis is made with an endoscopy if the patient is acutely obstructed, and you could actually push the food usually through the Schottky ring. Okay? So, we're pretty sure this patient has a mechanical dysphagia, and based upon his history, we think that it's going to be a malignant dysphagia and one of these two cancer types. Let's go back to the original question I asked you. Which test would you do in a patient with mechanical dysphagia with the choices I gave you? Manometry. Do you think this guy has a motility disturbance? Do you do a chest CAT scan? I said, that's not a bad choice. Esophageal cancer, I want to stage the patient, see if there's lymphadenopathy. Esophageal cancer, after all, doesn't spread to the brain or the liver. It first spreads locally. So it's a reasonable choice, but is it the first step? No. Endoscopic ultrasound. What's that? It's now standard operating procedure that a patient who we think might have a cancer in the esophagus, as part of their staging workup, once you know they have cancer, you do an endoscopic ultrasound. The gastroenterologist takes a scope that has a video chip, so he or she could watch where the scope is going, just like a regular endoscope, and then flicks a switch, and now at the tip of that scope is also a sonogram probe. So now, with that sonogram probe sitting right on the cancer, the gastroenterologist doing this EUS, endoscopic ultrasound, will see how thick, how deep the cancer goes, and how far it spreads beyond the wall, whether there are lymph nodes. And since you're putting your probe right on that cancer, it's even more sensitive than CAT scan in assessing local tumor invasion. A CAT scan is more useful because it'll tell you what the whole chest looks like, obviously. But the endoscopic ultrasound is a more specific test to tell you about local invasion, because esophageal cancer can only be cured when it has not spread beyond the full thickness of the esophagus. And unfortunately, by the time patients have the same picture this fellow had, they're usually already gone through the full thickness of the esophagus, and we can't offer them any chance for cure. Okay, so that's patient with mechanical dysphagia. Let's say I gave you a history, and there's a bonus question in the next case where we won't discuss it on the tape, but you'll be able to read about it. And it's a motility type dysphagia, where the patient will describe from the beginning that there's a problem that suggests motility. If I have a motility disturbance, I will do a test to measure motility. And what's that? Esophageal manometry. The gastroenterologist puts down a probe. Patients awake so they could take swallows, and that probe gives us pressure readings, and we will see what the peristaltic wave looks like in the esophagus. Now, for step 3, these are not the internal medicine boards or the gastroenterology boards. You don't need to know how to interpret manometric tracings, but I'll illustrate one because it makes it very clear to understand the pathophysiology. This is time. Okay, as time goes by. These are different points in the esophagus. This is, let's say, the upper esophageal sphincter. This is 10 centimeters, 20 centimeters, 30 centimeters, 40 centimeters, which is actually right around where the 40 centimeters from the teeth, which is right where the lower esophageal sphincter lies. Okay? The esophageal sphincter, upper esophageal sphincter, is usually a high pressure zone. Remember, what's the job of any sphincter in your body? It's to create a barrier between two areas. Right? Why do I want a sphincter at the top of my esophagus? Why do I want a high pressure zone at the top of my esophagus? Because when acid comes back, I want to prevent it from going into my lungs. I want to keep it in the esophagus. All right? So the upper esophageal sphincter is at rest, is contracted. If I swallow, the pressure in the upper esophageal sphincter falls. Okay? And then, what happens in my esophagus? At rest, I don't have a high pressure in my esophagus. My esophagus is not sitting like this. So the esophageal pressure is low. And then, as this patient swallows right here at time 0, all right? And then, as time goes by, that food bolus, or the liquid, typically, that the patient drinks, will move down the esophagus. And what happens? Well, when the food reaches the 10 centimeter mark, you'll see a pressure wave, because the esophagus at 10 centimeters is trying to push it down. And then that wave passes in the esophagus at 10 centimeters, goes back to rest. Then a second later, it's at 20 centimeters. Then a second later, it's at 30 centimeters. And then the lower esophageal sphincter, which again is high pressure zone, because it's a sphincter trying to keep gastric acid out of the esophagus, is high pressure until that bolus that you swallowed comes, and then it goes like this. Okay? So your sphincters are high pressure, and then you see the peristaltic waves proceed down the esophagus. Right? That's normal, manometry tracing. Let's say I tell you a patient gives you a history of motility-type dysphagia, and I tell you that the tracing looks like this. Upper esophageal relaxes. Okay? You swallow, the upper esophageal sphincter relaxes. Then what happens? You see any peristalsis here? You see those orderly peristaltic waves? No. This esophagus, do you see any contractions going on in this esophagus? No. As the liquid is passing down the esophagus, just by gravity, because I'm not getting any peristalsis, and it arrives down the LES, does it relax to allow that fluid into the stomach? No. So here we have no peristalsis, and LES that doesn't relax. Let's give this condition a name. Achalasia. Okay? Usually onset is slow, over weeks or months. No peristalsis. LES doesn't relax. Okay? It's also found in patients who have infection with a particular kind of bug, which you're not going to see unless you practice in Brazil, or you see patients who come from Brazil who have been bitten by Trypanosoma cruzi and has Chagas disease. It's what every American learns in the first year of medical school, and then we take that to our grave without ever having seen a case. But that Chagas disease causes a cardiomyopathy, and it causes a loss of innervation throughout the GI tract. You don't get esophageal peristalsis, you don't get colonic peristalsis, the patients can't swallow, the patients can't move their bowels, they just feel like they're going to explode all the time. All right? That's Chagas disease. It gives you an achalasia-like picture. Okay? Let me give you another disease. Let's say I tell you this is a middle-aged woman. Tells you she has progressive symptoms of motility-type dysphagia. And I draw her pressure tracing like this. Upper esophageal sphincter. Do you see orderly peristalsis? Yes or no? No. And the LES, which you saw in the past few tracings, how it looked, the LES is like this. So describe this. No peristalsis and LES always relaxed. What disease is this? Scleroderma. Middle-aged woman typically, maybe Raynaud's phenomena, maybe or maybe not other signs and symptoms of scleroderma. Why does this happen? This happens because the smooth muscle, the esophagus, except the very upper part of it, which is squamous. The rest of the esophagus is smooth muscle. So scleroderma, sclero. You get sclerosis not only in the derma, but other places where you have smooth muscle, including the esophagus. So your esophagus, instead of having smooth muscle, is just replaced by collagen, and it doesn't peristalse well. Your lower esophageal sphincter, another smooth muscle, which is again supposed to stay contracted at rest, is instead wide open. Okay? That's a patient with scleroderma. Motility-type dysphagia. Okay? Looking at that picture, what other condition do you think patients with scleroderma would be prone to in the esophagus? Barrett's as a result of GERD. Because this patient, instead of having a lower esophageal sphincter that should be tight at rest and preventing acid from coming up, has that lower esophageal sphincter always wide open. So acid is chronically coming up. And these patients are prone to Barrett's, they are prone to peptic stricture. If the scleroderma patient then develops a peptic stricture, what will they have? They'll have their transition from a motility-type dysphagia, and with chronic GERD, they might develop a peptic stricture, then they'll say, well, now I have mechanical-type dysphagia. Okay? That's the long and short of it on dysphagia. Knowing what kind of dysphagia will give you the short list of differential diagnosis, both for mechanical and for motility. If it's a mechanical problem, you'll either do an endoscopy, because that also allows you to biopsy, Or if they don't give you an endoscopy as a choice, you could do an upper GI series or an esophagram. We have the patient drink barium, and it'll give you a picture of what the esophagus looks like. But then again, most forms of mechanical dysphagia, you're going to want to get a piece of tissue, because if there's a blockage in there, you're going to have to determine, is that blockage benign or malignant? So the best test will be an upper endoscopy with biopsy. Okay? Whereas if it's a motility type dysphagia, patient with scleroderma comes in with motility type dysphagia, endoscopy would be the wrong first choice, and there an esophageal manometry will be the right first choice. Okay? Everybody got that?